Do you know Dr. Dan George?
I do. He's a good guy.
Is there any great difference between their protocols in Duke and what you have here?
You know, it's funny. We haven't sat down in a room, those of us that do this, and compared what people do. I think what we sort of just from talking at meetings, some people use more saline, other people I use Hespan and pressors and run people pretty dry. I think, you know, everybody kind of has a pattern that they use to do it. And, you know, we don't really try to do something identically as long as we can get the drugs into people. So I just know he trained in Boston, so he's had a lot of experience with it. And I don't know how many people they treat, you know, on a monthly or yearly basis there. But if there's anything there, it's microscopic at this point. But we don't trust that.
I'll be back.
Okay.
Did you say we don't trust that?
Well, right.
Yeah, I don't trust that either. So we're singing off the same sheet of music. From you know.
Do you
with that.
approach Dr. George?
No, I'm here first, and Dr. George has all these scans. He has agreed to see me,
Okay.
and I just wanted to have this. You're like a rock star. I just wanted to come and meet you. So.
Oh man, what do I tell my patient who's a Jerry Garcia fan that I'm coming into their league?
Let's see. Are there any trials that maybe connect IL-2 with other immunotherapies?
Not yet.
Nothing?
Not yet.
Okay.
I mean, the other things that you've been doing your homework, but the other things that are being looked at is anti-PD-1, which is takes the brake off the immune system. Mm-hmm. Now that is going into not combination trials, but it's going into dose-seeking trials. And I don't remember how much prior therapy you can have had for that, but you have to have measurable disease.
Mm-hmm.
So any clinical trial, you've got to have something you can measure, and they
Right.
don't generally take bone only.
Right.
The other drug that is coming along is a drug called XL184, which is really they're pushing it for prostate cancer, but it definitely it's an anti-VEGF plus an anti-MET, and it definitely has activity in renal cell. And it appears in the reason they're pushing it in prostate cancer, which tends to go to the bone, is that they've actually shown pictures where the bone scans have normalized.
Wow.
And it's not just, I thought maybe they just interfered with the scan,
Mm-hmm.
but they see markers of bone destruction going down, they see pain scores going down. So it looks like it really is active, and it does seem to do something in bone lesions. So that, the company is putting all their eggs in that basket for prostate, but they also have a couple of renal studies that they're going to get published, and then that way that can go into what's called compendium approval, so that insurance will pay for it for renal cell. So I think those would be a couple of things to just keep in the back of your head.
One of our friends in Columbus has a daughter that will visit the National Institutes of Health, and she is in the renal cell research side. So she obviously hasn't given me any proprietary information, but there are some trials that aren't really being talked about out there much that are ongoing, or so I've read all those, I read all that. Don't remember anything much about it, but
well, this stuff looks fine. It's fine. And are there any places elsewhere in this
No.
one? No.
Just in my back.
Just that L2.
Mm-hmm. And the thing is, it's just in a really bad place.
It is.
And if it chooses to take off again, it's probably going to cripple me.
Yeah.
And major change of life, and I would like to, I talked to my radiation oncologist, and his words were, something like, it reads like a horror story. You can't have no more radiation there. And he just said at the end of that email, we do not want this tumor to come back. And I mean, theoretically, it has come back twice now at about 9-month intervals, and I feel like I'm just sitting here waiting on it to happen again. You know?
Yeah.
Or pop up somewhere else.
Mm-hmm. Or pop up in my lungs or my brain or the other places that renal cell likes to go.
You never know. So otherwise, medical problems, just a little hypertension,
Yeah.
hypothyroidism,
I mean,
heart problems?
no,
Have you had a stress test?
not in a long time, but I know I'd have to do that.
Yeah.
I mean, I played golf and paddled a kayak, and I was very active up until the time this started taking some of my life away from me.
Okay. So, I mean, what we usually do is we do a stress test and pulmonary function test just to know what kind of reserve there is. We do a brain scan because we want to make sure there's nothing hiding that would cause problems if we caused some edema.
Right.
I would think that you'd want either a neurologist or neurosurgeon around just to make sure that if there were to be some swelling along where the tumor is, there wasn't a compromise. But you know, you wouldn't want to go on Decadron unless it was absolutely necessary, because that would shut down the interleukin 2 completely.
Now, I had Decadron after a surgery, but it's been 2.5 months.
Yeah, but you're
Since
not on
then.
it now.
Not on it now. Not on it now.
So,
The other thing that I know that I would want to stay away from any kind of the drug like the Decadron, even if it's a topical
Correct.
thing. You know,
Correct.
what is that called?
Steroids.
Stay away from all steroids.
yeah.
Um,
I mean, there's varying degrees of them being absorbed, but they are. Had to look this up for somebody else who was bugging me because he wanted to take it for his skin stuff, and I said, you just can't.
Yeah, because I have, if it's summer, I have constant problems with poison ivy, and I know that cream that they give me has some steroid in it, so I would just have to tough it out, I guess, if this were the summertime. So
Or stay away from the
It's
poison
in the
ivy.
yard.
yeah, well,
We live out in the country. It's
Oh.
everywhere.
I'm a tractor, so.
Well, at least initially.
And so you think that this is the next right step for us?
I think it's. Yeah, I think it. I think so. I mean, why would you do something? I mean, the issue is whether it will work. Because what we don't know is, do you need to have visible tumor for the immune cells to recognize it? And that part we don't know. But we do know that there are people who we've treated that don't have anything show up anywhere else. So maybe it is doing something in the micro setting as well. And we just didn't have enough patients, or the response rate is so low in general that you couldn't tell a difference in the adjuvant setting. So I think your choices would be to wait for something to happen or do something. And if your choices are, TKI versus IL-2, the way I look at it, you do the IL-2, if it works, you're done. If it doesn't work, you've still got about 6 different options, plus new drugs coming down the pike.
We're of the mindset that we're ready to do this starting now, like next week. We're ready to do it.
Okay.
And so I just don't want to sit around and wait for what I think is going to happen. I think that tumor's going to come back up in my spine, and I just can't have that. I'd rather take 5 weeks out of my life and roll the dice and see if we're responders,
There are probably 3 places south of D.C. that do IL-2. There's Vanderbilt, which is over in Nashville. There's Duke. And then there's a fellow that was he's a surgeon, but he was at the NIH for a long time, and now he's in Charlotte, I think, North Carolina. Just so you have several options. But I mean, Dan, I have absolutely no problem with him. I think that would be
And Dr.
fine.
Pippas trained with him at early on, maybe at Duke. They were colleagues, so they have a
Okay, so that's
long
even better.
relationship.
Well, how do you measure whether it's
Working or
works
not?
Yeah.
Well, you don't know. I mean, you can't really see anything on this scan. So the only way, unfortunately, that you're going to know either way is if something comes back.
Yeah.
If it never comes back, you can either say they did a great job with the stereotactic and give them credit, or you can say, well, it was the IL-2, or maybe the two of them together. You know, there's some suggestion that the radiation, although we don't know what the timetable is, can actually release antigens and make immunotherapy even more effective.
And so what kind of success rate do you have?
Well, with IL-2?
Yeah.
All right, so I'll tell you what we do. We do 5 days, and he may do it a little differently, I don't know. We do 5 days on, 9-day break. This is the old original NIH regimen, and then 5 days. And we give it to start with every 8 hours, and then usually goes to every 12. And so usually it's between 8 to 10 doses the first week, sometimes a few more. And the same thing here, but everything happens a little faster the second week.
Because it's almost like cumulative. So if you took 8 here, your first dose here is almost like dose 9, right?
Right.
In terms of the way your body reacts to it.
Well, what I say is, usually what I say, everything happens a day earlier in the second week.
Okay.
So you might not be quite like you're right at the end of the week, because you do recuperate. By the end of that week, you're pretty much back to normal, or it seems that way. And the things that bother me as the doctor are the low blood pressure, and you have to come off your blood pressure medicine a few days before you start. The low blood pressure, rapid heartbeat, that's why we do a stress test, and low urine output. And so your creatinine's going to be a bit of a rate limiting step. Some people, we even do a moderate dose, but I would probably do the high dose if you can. And you just have to modify your parameters. You say, okay, our baseline creatinine's 1.8, so we'll let you go up to 4. Everybody reverses. It's just that you're watching everything get out of whack during the time.
Right.
The things that bother a patient generally are, sometimes you feel funny with the low blood pressure, but let's see, diarrhea, which doesn't happen to everybody. Some people get nausea. Doesn't happen to everybody. Swelling, itching, and then probably insomnia to some degree. Whether that's hospitalitis or whether that's...
You're awake and aware of everything, or is he out?
No, you're
knocked
awake
out?
and aware.
Okay.
You're awake and aware. The only reason we do it in the hospital is because it's around the clock.
Yeah. Okay. And what happens during these 9 days?
So you say you go Monday through Friday, and you last dose Friday night. You go home Saturday. First 24 hours you sleep, because regardless you're not getting a lot of sleep. And then each day you get better. You feel really sluggish here, and then by the middle of the week you're pretty much getting up, walking around, doing stuff. You're eating better. If you put on a lot of fluid during this week, you'll get rid of the fluid. You probably will have actually lost weight, because in fact people don't eat as well.
Yeah.
But they gain water weight, and then the water goes away, and then you're down a little bit. And usually by the end of the week you're ready to go again.
And so when you say you go home, do you just need to go somewhere near the hospital, or you literally could go home?
You can go home.
Oh, so you don't have to be, close.
We don't make people. I mean, we usually that's right, you're going to be even long distance if you're there. We have had a fellow that flew in from California. Why he wanted to come here? It's got relatives in New Jersey, I guess. Anyway, so he actually flew out the same day, but mostly we say, wait 24 hours, stay overnight, and then, if you feel okay, go home. But we've had people drive back to Maryland, for example, overnight.
So you don't need anything in between. You just
usually not. The only thing that
rest.
sometimes you might need is if you're really fluid overloaded. is the water pill,
Mm-hmm.
and that can be called in.
Mm-hmm.
But not everybody, most people don't need it because you diurese on your own. The other would be itching. Sometimes the itching can be really annoying, and it doesn't respond to Benadryl. It's not histamine, it's cytokines. So for the itching, we use gabapentin, and this is something that we invented. So not everybody knows about
I've read
this.
about that.
But it really does make a difference because it's itch fibers or pain fibers.
Is that the same thing as Neurontin?
Mm-hmm.
Yeah.
Yeah.
All right, and so then 5 days, 9 days, 5 days, then what? Come back.
Then we usually repeat the scans, although we won't know what we're looking at. Repeat the scans at 6 weeks and 12 weeks to see if there's been, usually the 6-week one we just want to make sure there's nothing bad happening. The 12-week we may see something or may not, but I don't really exactly know when your scans should be done. I mean, I would certainly do something right before, I think, and then maybe wait and just do the 12-week scan because you're not expecting, if you don't see anything pre, you don't expect to see anything post.
And so then, is there a chance when you did the 12-week scan that you have to start this all over again?
Some people do on schedule. Some of the cytokine working group studies, you'll see that they got started again at 12 weeks. I tend to wait and see what the maximum benefit is and then start again. Like if somebody's had a little bit of shrinkage, then at 12 weeks I might get a scan in 2 more months and see. And if it's a little bit better, go to max and then retreat if they don't have a complete response. The response rate, as you asked me before, with IL-2 is about 30% overall. And that's when you have visible tumors. It's 30% go 50% smaller or better. And about 7% completely go away.
And stay away.
And stay away. When they go 50% smaller, a lot of times they'll stay away for a couple of years. And you can retreat. And if you retreat, about half of people will respond again.
Knowing what his scans show, do you think our insurance will pay for this?
Your diagnosis is renal cell cancer. Metastatic. That's all they need to know.
Oh, okay.
Okay.
They don't need to know what the scans show. Expect to see anything post.
And so then, is there a chance when you did the 12-week scan that you have to start this all over again?
Some people do on schedule. Some of the cytokine working group studies, you'll see that they got started again at 12 weeks. I tend to wait and see what the maximum benefit is and then start again. Like if somebody's had a little bit of shrinkage, then at 12 weeks I might get a scan in 2 more months and see. And if it's a little bit better, go to max and then retreat if they don't have a complete response. The response rate, as you asked me before, with IL-2 is about 30% overall. And that's when you have visible tumors. It's 30% go 50% smaller or better. And about 7% completely go away.
And stay away.
And stay away. When they go 50% smaller, a lot of times they'll stay away for a couple of years, and you can retreat. And if you retreat, about half of people will respond again.
Okay.
We're at a point now where we're having to make decisions to cut the baby in half. You know, these decisions are big, and because the consequences are big.
Right.
So.
Do you
Is
have
there anything else
that you need to know?
that he
Or
could try?
that he could try other than this? Well, okay. So well, you know what the other options are. The options are the TKIs, the mTOR. The only other immunotherapy that's available but not approved, you probably won't be able to get it for renal cell, is ipilimumab. And this one we don't really even have a good data in renal cell. We have one phase 2 study from the NIH. This was approved for melanoma. It has activity in renal cell, but it's never been evaluated formally other than that phase 2 study. So it's $120,000 a pop for 4 doses. So you're not going to get that. And it would be based on very little data. Mm-hmm. I think the best data for what you have truly is IL-2. Because even if you ask people about bone disease with the other drugs, they don't know whether it works or not.
Mm-hmm.
Sutent, does it work in bone? We don't know. We think probably, but so I think there definitely is data for IL-2 in bone or soft tissue, but the cells can get there. There's been inflammation there, so the immune cells can get there. I would not forget about these other 2 just because they'll become approved, but you won't be eligible. There's no ongoing renal trial. And this one you won't be eligible because of no measurable disease.
Mm-hmm.
So, you know, it may get approved within the year, in which case it'd be another option down the road if it becomes necessary.
Mm-hmm.
But I think right now it's really either anti-angiogenesis or immunotherapy. The only other current immunotherapy would be interferon, which is like having the flu all the time. I mean, it's less intensive because it's outpatient.
Mm-hmm.
It's a little bit less active too.
Yeah, I'm willing to do whatever I have to do to try to hit it out of the park, and that's
Yeah,
the
I think
one
so.
that I think I need to do. So
I don't know if you want to talk to a patient that has been through this.
I'm talking to them every day.
Okay.
Susan and Gary Poteet, who are in Oklahoma City, he's just finished up. I talk to these people, not physically on the phone, but we talk online. I know
Okay.
a lot about it, so, and I know it's a bear, but
Well, it's not as bad as everything you hear about
Mhm.
because it doesn't all happen to one person.
right.
And I think most people, like one patient who wouldn't go to sleep because he was afraid that when he woke, he wouldn't have any blood pressure if he went to sleep. Lo and behold, 2 days into it, guess what? You still have a blood pressure, so you can relax. You know, I mean, I know that people get terrified because they hear all the horror stories, but
Mhm.
you know, it really is like the worst flu you've ever had. But you get over the flu and you get over this.
Mm-hmm. Well, I'm.
But it's idiosyncratic. You can't look at somebody, can't look at their labs. You can't say, oh, everybody with a high creatinine. There's no correlation at all. No correlation with the amount of disease. Nothing.
Mhm.
Personality. No.
And this treatment's you've been doing this for a long time, haven't you?
Yeah, since 1986.
Yeah.
Yeah, we've tried everything we can think of to make it more better, you know,
Yeah.
to try to enhance the response rate. The only thing that has been shown still, you know, we tried this, we published it or presented a year ago, is clinical stuff. It's basically people that are good performance status, clear cell, and that's it. And we don't really have any, you know, we don't have an immune profile that's been predictive. We don't have a pathology profile that's been predictive. So it's very frustrating because if we could tell people you will definitely have a good chance of responding, then you could really select people out. But we haven't gotten there yet.
How do you determine 8 doses versus 10 or 12?
Well, usually we start. There are other people. For example, there are people at Yale. They will plan 10 doses because they'll just give it twice a day. I usually start out. I don't know that isn't okay, but I've always started at every 8 hours. So the first 2 days, it's usually right, you know, pretty much on target. And then what happens is you don't recover from the next dose by 8 hours. Your blood pressure's still low, or your heart rate's still fast, or you're on blood pressure medicine at a high level. We have to get it back down. So then you end up getting it every 12 hours.
Oh, okay.
And so that's how you. And then I don't give anybody anything past midnight on Friday because otherwise you won't recover on Saturday. And you know, one more dose is not going to matter. So
Yeah, okay.
that's kind of where it stretches. I mean, the original protocol was 14 doses, but nobody gets 14 doses, so I don't even try to tell people that anymore, because then they're counting, you know. It's like, oh, I didn't get enough.
Right.
There's no magic number. It's your level. The dosing depends on your level of toxicity, and what I always tell people, the way to give IL-2 safely is to know when not to give a dose.
Mhm.
That's the thing you need to be able to tell.